Thank you, Ian, and I'm delighted to be here to try and give an NHS perspective to what I think is a real exciting opportunity for the North West, the North, to deliver something for the NHS that is of huge benefit. And this is the test bed that we're talking about. This is the health profile for Manchester for 2012, and you can see whether we're looking at the deprivation across communities, we're looking at young people's health outcomes, the burden of disease, mortality for patients in Manchester. These are only really matched by Salford, interestingly, and by a few boroughs in London. So wherever we're looking at, we know that our patients have a high burden of disease, and we know there's a lot of work that we need to do to try and improve that. So how can we start to make an impact on this? And the main driver for me is looking at how do we alter patient outcomes across a whole conurbation, across a whole population? How can we start to get into the areas of prevention, but more interestingly in particular, to get into the area of earlier diagnosis and earlier intervention, to start to alter the pattern of disease and disease development across this deprived population that we serve. Even with the risk adjustment that's applied to health outcome data, to mortality data, imprecise as that is, our health outcomes are okay. They're about average. But we know that in Manchester and Salford and the North West, in other areas, our patients die about 10 years younger than they do in other parts of the country. So the implication of that for me is that burden of disease, is the diabetes, the cardiovascular disease, the chronic respiratory disease and so on, that actually means whatever we do in other areas, there's an impact for patients in terms of outcome. We are awash with data in the NHS, but as this previous librarian in the American Congress said, we haven't got a lot of knowledge and information from all that data. We use our 1,400 electronic databases in central Manchester to manage patients, to track patient care, developing huge volumes of data sets for individual patients on basic physiological measurements. We've got a raft of laboratory data. We use data to manage staff. The way we buy in kit is the NHS, the NHS supply chain. They have 600,000 service lines. It's not rationalised, it's not coordinated. Which ones are better? How do we make a difference to that sort of system? When Ian and Martin Gibson came to talk to our exec team about North West eHealth, we were hugely enthusiastic. We were bought on it. The reality is nothing's happened. We haven't been able to integrate our systems in a way that will allow us to move forwards, and that's a real driver for this sort of program that we need to grasp and move forwards with. From a regulatory and commissioning framework perspective, there are a plethora of organisations who are empowered to visit and inspect NHS provider trusts, looking for information, looking for data, and it's just not coordinated in any way whatsoever. So Monitor will come and ask for a whole raft of information. We'll want the same information for the NHSLA, but it'll be in a different format. So there's a lot of data around, but there's no cohesion, there's no picture of deliverability, and the very failure of Connecting for Health to actually start to deliver some of this so dramatically a few years ago just spells out what the problems are. And the Department of Health has grasped the need for the NHS to embrace the digital world, and commissioning for quality and innovation is a program whereby NHS organisations are incentivised to innovate, to actually track progress. And one of the gateways for that is using digital technology, either in telehealth, digital by default, and so on. The challenges are significant. I've mentioned Connected for Health. There are commercial products available, but none of it adds up. None of it is integrated, none of it is cohesive, none of it gives me, as a medical director, a single focus for looking at what the issues might be and where we might start to change our services, to introduce innovation, and so on. I have to triangulate across a whole plethora of different data sources coming in. The perennial issues of privacy and ownership of data will are still there. Caldecott 2, that report from Fiona Caldecott that was produced last month is being launched today as we speak, with a whole new raft of requirements around privacy and data management. How we actually start to interpret the data that we're getting, how we actually manage, bridge that lag between the innovative design, the innovative product that produces data but doesn't integrate with the existing systems. That's a real challenge for, I hope, HeRC. And finally, really, is it going to make a difference? We've heard some good examples of where we can make a difference in terms of research. Is it going to make a difference to patient outcomes? I can well see that elite sportsmen will be very happy to self-track physiological parameters to improve performance. Will patients do the same? Will patients actually want to be reminded on a regular basis of their non-compliance with treatment? We have a challenging population who already make lifestyle choices, which may not be to their benefit. Is telehealth, is digital technology, is this sort of program going to make any difference? We'll have to wait and see. But I think the prize is potentially huge. And if we, as a conurbation of NHS organisations around Greater Manchester, can improve our life expectancy by 1 year, that would be a fantastic achievement. And I hope and trust that HeRC is going to help us do that. So I'm going to hand over to Martin, who's going to give us some examples of how progress is being made.